Welcome everyone to the PFCC Partners Community of Practice Workshop. My name is Lindsay Galley. I'm the Director of Education at PFCC Partners, and I'm very excited today to welcome our one and only Stephen Hoy, the Chief Operating Officer at PFCC Partners. Thank you, Libby. We have just enabled live transcription. So if you would like to use that, I believe there should be a little pop-up on your Zoom and you can click that to show it. We are recording today's session for anyone who would like to view it after who isn't available to join us today. Throughout our session, if you have questions as the presentation is going, you can put those in the chat and we can address them either at the end during our Q&A or in the chat. We have a few team members on who can help answer some of your questions as well, but we have plenty of time for a Q&A at the end of this session. Before I pass it off to Stephen, I just wanted to, acknowledge the heaviness that this week has brought to our country, especially the families and children in Texas. So just wanted to say our hearts go out to the state of Texas and any parents that are on with us with school-age children. I have one myself, so know how hard it's been this week. So our hearts are with all of you, and here's to healing and doing better for our kids in our country. And with that, I would like to introduce Stephen Hoy, Chief Operating Officer for PFCC Partners, and he is going to talk to us about something fun, get our minds off for the next hour. We're going to be talking about the Funfetti approach, or Stephen's going to be talking about the Funfetti approach to patient-family engagement for equity. This is something that we're really passionate about and very excited to bring this to our entire community. So please, ask questions away. We got a lot of good questions in the chat or in the registration prior to this. Yeah, with that, I will pass it off to Stephen.
All right, thanks, Lindsay. In addition to the burdens of this week, I've been struggling with something that feels and looks like COVID, but all my tests say is not. So forgive any coughing attacks. Fortunately, my whole team is on board and can help me cover. But also, like Lindsay said, so passionate about this particular topic, and above anything else, metaphors, the king of metaphors around here. Love simplifying complex issues, problems, or challenges with metaphors. So the Funfetti approach, we'll get to. I'm Stephen Hoy. I know it says Chief Operating Officer up there, but the only reason I have that title is I'm the oldest of three boys living with chronic mitochondrial disease. The three of us have had 36 surgeries in 16 different health systems across the country, 3-year search for diagnosis, ambulatory visits, and we're all doing great due to a person-centered care. Even included with 16 specialists, something like 8 specialists following all of us. And that's due to an incredible quarterback of a mother. Proof that the person-centered care approach works. I often call myself a triple aim, so a walking triple aim. So although it says Chief Operating Officer, know that my experience comes first in the patient and family side. And that's important to note, is all of our approaches are to patient-family engagement are built on a kind of unique understanding of what context, preparation, and supports are needed for really impactful and sustainable engagement. In the course of our work, I've served as a patient-family advisor everywhere from my local Mammoth Hospital up in Mono County, California, 16-bed critical access hospital, to Institute for Healthcare Improvement and Centers for Medicare and Medicaid Services. And across that work, I think I've shared some experience, some things that a lot of my advisor friends can relate to, and that's being a part of a checkbox effort. Having our I think Libby could surely fill the whole hour with horror stories from the early 90s of this work, to the point where she actually turned coined the term "yeah butters." It's you may have come across a "yeah butter" in your lives where where their response to your brave sharing of a story or your suggestions for improvement are met with "yeah, but." And some reason why that can happen. And there's really nothing worse than having your contributions limited because we're engaged, kind of too late or after something was fully developed, whether that's a patient portal, hospital signage updates, or quality improvement initiative. With that's kind of superficial engagement, advisors are denied access to decision-making process, and interactions often tend toward tokenism and marginalization. Our voices are simply informed of plans or consulted to provide limited perspectives on select activities. And we, excuse me, I'm so sorry. I hope you can hear the words instead of the coughs. But we're just not as impactful when we're sprinkled onto a cake after it's baked. So we want to bake patient-family engagement throughout cakes, all the way through, not sprinkled on top. We work with health systems improvement projects across the system to build these patient engagement strategies, and need to recognize that some of our members want to engage in a variety of ways. Some value the convenience of surveys or one-to-one interviews. Some desire larger, committed, shared decision-making roles, and others are only comfortable sharing their lived experiences in a coffee shop. And our patient engagement efforts need to be tailored and fluid enough, as fluid as relationships are. So we're going to talk about how to meet people where they are so organizations can engage diverse voices and inclusive activities. I'm not going to do, I think, a blessing of this year's, we're doing a little bit less of the case making for patient engagement, and we're going to focus today on the how to do that kind of stuff. But if you'll bear with me, we'll cover some of the vision for this stuff. This is what PFCC Partners is all about. We want to see a health system transformed into one that works with people and through communities as a partner in their well-being. We catalyze system improvements by centering that human experience of health. And we absolutely recognize the critical role community engagement plays for any effort at delivering health equity. So we made a pretty simple graphic to define our two kind of our projects, our organization and our projects, PFA network. Healthcare, we know it's complex, millions of dollars, hundreds of people, hundreds of agencies. All of them have influences on the care we receive, and it's it's hard to make change and improvement sometimes. So what PFCC Partners does is help open space within the health system for patients and families to drive improvements. I think it's something we need most now. And as PFCC Partners opens that space, which is strategic in a way, it's aligned with key levers for change in our health system that we see essential for advancement. We then have and facilitate the PFA network, over 800 members across the country who leverage their lived experience, who lean on their lived experiences to improve healthcare. And that's just a little background on how the two relate. You'll hear me talk from professional experience in working with our health systems and my personal experience as a patient family advisor, and know that kind of we sit on both sides of the table here at PFCC Partners, and I think that's what makes us a little unique in that we facilitate the 800 plus voices in the network getting engaged with our health system. It gives us that really unique understanding of what people need to get engaged, as well as systems to do engagement well. And if person-centered care is our vision, patient-family engagement is how we get there. Livy coined it. It's an active strategy to achieving whatever outcomes you're hoping for. Patient-family engagement is your strategy. We say it's not new work. It's a new way to do the same work. Whether you're working on readmissions, collapse prevention, or health equity and reducing disparities, engagement's going to have to be a foundational strategy. Engagement is the process of working collaboratively with and through groups of people who share similar situations, concerns, or challenges to address issues affecting the well-being of those people. Meaningful engagement serves as a powerful vehicle for bringing about systems change that improves the health and community of its members. You'll hear me talk a little bit about, you'll hear me go back and forth between patient-family engagement, community engagement. I see patient-family engagement as engaging individuals around their unique health challenges, health situations, and community engagement being engaging people for being members of certain communities, certain zip codes perhaps, or maybe historically underserved or underrepresented populations. A hallmark of good engagement means deferring decision-making power to the people we seek to engage. We recognize, the importance of providing multiple pathways to provide input. And that's really what the Funfetti approach is about. How can we bake sprinkles, throughout our cake? And we know these voices and engaging patients, families, and community members create motion and catalytic action that moves us toward health equity and well-being through transformed systems. The National Academy of Medicine reinforced that this year. Big thank you to them. And really opened our eyes to how the new era of patient-family engagement needs to be as fluid for our organizations as we've made it within our network. It's all about relationships, and a lot of efforts in the past have been focused on PFCs, which have been a great start. This isn't to replace PFCs, this is to layer on top of, and having a comprehensive approach to engagement ensures a higher diversity of perspectives, and inclusion of people who historically haven't been able to engage with the system due to lack of volunteer time, for example. If you want to read more about why the National Academy of Medicine, how the National Academy of Medicine views the community engagement and health equity conversations, Lindsay's going to drop that into that resource into the chat for you here. Great read when you get the time.
Now, who is the risk manager that covers?
It's somebody else. I think my text will take care of that. Well, I keep on going into the fun part. All right. So how do we do this? This is the part I've been excited to share with you guys. A little bit about how we've approached it within the network and our subsequent hubs and with all of our partners. The butter and cooking spray of this recipe is commitment and resource. I mean, sometimes and often underestimated the level of commitment and resource to do engagement well, but that doesn't mean we can't get started with just one single individual and a minimal budget. We've seen amazing things happen and huge snowballs made because of those efforts. So just know that it can happen with any size of commitment and resource. But if you don't have it, your cake's gonna come out of that pan and crumbles. The most essential piece to do it, to organizing a project like this or a patient engagement strategy like this, is a relationship management system. For us, we use Salesforce, a converted Salesforce. It helps us catalog both people's interests, communication preferences, lived experiences. We ask the magic wand question. That gives us great insight. If you had a magic wand, what's one thing you'd change about healthcare? That really helps us place advisors where we see alignment with their lived experiences and their priorities and their passions. It also allows us to track where and how they're engaged across projects and engagement and opportunities. So pretty essential to think through your relationship management system, how you're going to track everything. We use Salesforce if that's expensive. Another great tool is Smartsheet, if you haven't heard of that. Very affordable, shared sheet with the ability to make notes and add attachments. highly recommend that. You'll need a communication method, so go ahead and think through that. We use Google Groups most often, but any type of listserv communication method, you're going to want to be able to send something out to all the advisors you're collaborating with on occasion, and really consider an online community space. We host that on the network website, but naturally, us patient family advisors, we want to talk with one another. We want to stay connected. Even if I go work on a patient portal and my friend works on a readmissions task force, we find that the advisors still want to get together and support one another. So consider a virtual space for that as well as a physical space. The other things we leverage, advisor interest form. So that's for new folks considering coming in. Again, we use SurveyMonkey for a lot of these next three. SurveyMonkey. We take in their interest forms, their availability, their communication preferences, and that helps us create a catalog of where people are and just amplifies the way we can facilitate their engagement. An opportunity request form is pretty crucial as you get started. You can give members of your organization or project team this form. Also, SurveyMonkey, Smartsheet works well for that too. Smartsheet has a form piece where they fill out the form and it drops it straight into your Smartsheet. And that's made it really seamless for us to respond to requests. We used to get, hey, do you know somebody who'd be good for this? We'd get that request about once a month 2 years ago. Now I think we get it once a week or more. So and that's only a good sign. So you want to have that scalable resource built when you get started, or as you get started, to help you track all those people who want to engage with the advisors in your community. And I say in your community rather than in your PFAC. Again, not in replace of, but as an evolution of. We've seen a lot of organizations start with PFACs, and eventually, as PFACs develop, it grows into this community of advisors. Lindsay's going to talk a little bit about more about that evolution, but it is a distinct difference in the Funfetti approach versus the PFAC is it's community focused. And that allows us to engage on multiple levels and with multiple levels of commitment for advisors. But with no matter what, we want to be evaluating the engagement on both the health system side and the patient family advisors. We're going to debrief. How did that go? Tell us any obstacles or any interference you came up with. Tell us some of the bright spots and give our staff the same chance to do that. We are a continuous improvement organization, so that goal to do better never really ends. We get a lot of questions about the translation and people with hard of hearing, and we have been using Zoom's capability for that. You can what do you call it? You can set somebody as the translator on Zoom, and they'll hear the presenter at 20% volume and their language of preference at 80% volume. And it allows us to have simultaneous translation back and forth across multiple languages. So Zoom's platform is available to do that, as is its American Sign Language interpretation. So use Zoom. You can use Zoom for engaging with in different languages and with using American Sign Language as well. Let's see what else have we done. One more idea I have for you guys that we learned this week was Jamboard. You may have used Jamboard in a number of these webinars since COVID came around. It's a pretty great tool for interactive meetings and people to post their insights on. We've started leaving those open past the meeting, and it allows our patients and families to give us input whenever they feel like it. You know, I share that. Some of my greatest insights are always on the drive home from the meeting. I can't come up with them in the meeting. I'm too scared about coughing too loud or making a fool of myself. But when I'm driving home, I have that idea, and leaving the Jamboard open allows me to go back in and provide those insights after the meeting. And we've gotten a lot of good stuff from leaving that opportunity open even after the meeting. We call that a good pro tip. So those are some of the ingredients, those things to get together before you start cooking your funfetti cake. But the cooking is the crucial part, right? I'm gonna take a sip of water. And let me pause for any questions while I do that. Cool, that means I'm doing a great job of explaining. So facilitating inclusive engagement and equitable decision-making. Easier said than done, but we have some facilitation guidance created by our team over here. Lindsay will drop that into the chat for you guys to use as you move forward. But mix that in with a diversity of patient and family caregiver perspectives, and make sure it's representative of the population your organization and your projects seeking to serve. Do that analysis up front. Look at CHNAs or any of that demographic data that everybody's so keen on, and make sure the people you're talking with represent that. And you have to be intentional, really intentional and strategic about it. Opening a door to the PFAC is awesome, but if that's not reaching your patient population, you really want to consider some different types of activities, starting with interviews or listening sessions, or even topic focused. Yeah, one-to-one interviews are a great way to get started. We often say, Livy's been using this for years too, that buying somebody a cup of coffee is the international sign of goodwill. So go have a coffee with someone if that's what it takes. Keep expanding the engagement opportunities across your organization. So once you've built this resource and once you're establishing this community, we need to do the work to spread the opportunity for other staff, other team members to engage and establish partnerships. So that's a big role for our engagement program facilitators, is both supporting patients and families to get involved, and then helping staff like target or highlight the opportunities where the patient family voice might be most critical, and fostering relationships around that. Trust facilitation, we're all aware about the historical mistrust between our community members and our health systems, and trust is a lot easier to establish between individuals. So as a leader of patient engagement programs in your organization, you may consider yourself a trust facilitator at times, as your advisors work through your system or project. That we find that to be an effective place to start, where trust may be a scarce resource. The most important thing, though, really, is peer-led support, preparation, orientation, and debriefing. As a patient advisor, as Stephen Hoy, I know there's a quality committee. I know there's a safety committee. I know there's the billing department and ICD-10 codes and all these things. But the patients and families we need to hear from most don't necessarily understand that. And to break down what information is really essential for them to know to be impactful partners, and put work into preparation and orientation and debriefing so they can continue to expand their impact. It leads to the most sustainable engagement efforts in organizations. So what temperature do you set the oven at? Warm. Inclusive, inviting, and brave. We used to use the term safe space for sharing, but our DEI leadership council members helped us evolve that language. Conversations about racial health and equity are not always comfortable and safe, but they are essential for understanding and progress. So the term, we've leveraged now the term brave space. Some ways to improve inclusivity in your engagement efforts: go to comfortable spaces, restaurants of choice, coffee shops, parks, churches. I know we all love our office now that some of us are returning to it, but it's not always the safest or bravest space to have some of those brave conversations. Use group agreements to kick off your meetings, especially in PFACs or otherwise, and those quality improvement teams. If you're inviting people in to a quality improvement team, for example, you'd still want to use group agreements that are around inclusivity. And if you check our values, a diversity of perspectives is expected and respected at all times. So Lindsay's now dropped our group agreements and some ground rules for you guys to steal, use, or adopt as your own, if that would be helpful. But what we find also really helps set the stage for inclusivity is that engagement support. I can't say it enough. The preparation and debriefing, the checking in, that helps people feel and know that their voices are valued in the system. How do we know we've done it? We got the question in the registration somewhere, I think. What's your measures of success? And I'd say the fundamental question, I am the National Academy of Medicine, them first maybe, but fundamental question is not whether entities think they're engaging communities, but whether communities feel engaged. It's why we evaluate all the engagement opportunities within the network and within our extended communities. That it's our measure of success. We've got a few cakes in the oven. Our biggest one, of course, being the PFA network spanning across the country, but we have projects and partnerships with a number of these organizations and actually hundreds more. But I'm going to let Lindsay talk a little bit about what people are engaged in, what some of those activities have been, and some of the ways we've connected with historically underrepresented voices. Lindsay, you want to give me a talking break?
Yeah, absolutely. Thanks, Stephen. So yeah, just like Stephen said, we have been supporting the development of communities of patients and family caregivers in all of these different areas. First and foremost, our patient family advisor network, which Stephen talked about, and then, moving through. And I think I want to focus more on our work with Los Angeles County Department of Health Services. So within LA County DHS, we have been working with them for a few years now, and it really started when COVID started, and we had this great need to be able to connect with communities and connect with patients and family caregivers to really get a pulse on, what is going on in the communities. And so what we ended up doing was hosting a variety of listening sessions that were really open-ended, but just wanted to hear, what questions did the communities have about COVID-19? What about the resources? We heard the lack of toilet paper in the beginning of COVID, and that was something that came up. But we just hosted a few listening sessions, in that warm, inclusive environment on Zoom at the time. But so that was one of the first ways that we started to engage the LA County community in this larger community that we're calling the Patient Family Partnership Hub. Beyond that, these patients and family caregivers have been involved in DHS's equity, diversity, inclusion, and anti-racism listening sessions. They have had a really huge impact on virtual healthcare at DHS. We host monthly meetings, and during those meetings, we've had a big focus on virtual healthcare. So making the patient portal accessible, using virtual visits, ensuring that patients and family caregivers are comfortable participating in virtual visits and using their patient portals. So that has been a really big focus as well. And then beyond that, in LA County, we have also supported the development of, I think I want to say 11 patient family advisory councils as well. So throughout LA County DHS, there are health centers and hospitals, and each of them have gone through our process to developing patient family advisory councils for their local health centers and hospitals. So the patients who are being served locally can have an impact locally on those health centers and hospitals. Patient family engagement for equity at DHS is kind of two-pronged. We have that local patient and family caregiver voice, the community voice, that are helping to inform those local priorities and local strategies for each of those health centers and hospitals. And they're doing really incredible things to get in touch with the community. As Libby put in the chat, DHS is the second largest safety net health system in the country. And that was one of the things that we really stressed in both the development of the advisory councils and this larger community. We really needed to ensure that it was representative of the patients, that the representative of LA County as well. So locally, the advisory council facilitators will sit in the lobbies and talk with patients about the opportunity to be a part of an advisory council, or they'll go to the farmers market or other resource events that they have locally to really get a touch on that community perspective. And then we have the partnership hub, which really serves, the larger system that is the Department of Health Services. In what we've done is created multiple ways for people to participate in the partnership hub. So I mentioned we have a monthly virtual meeting. I mentioned we have hosted listening sessions in the past, but we've also created brief surveys for people to let us know. Maybe they have 5 minutes and they can tell us really quickly what they think about virtual healthcare at DHS. We also have an online forum for folks to go. So maybe they can't take that hour out of their Monday afternoon to join our hour-long meeting, but they can, maybe a little bit later that evening, go on an online forum, peer community, to let us know their thoughts about a specific topic. So, we're not really taking away from the patient family advisory councils at DHS, because those are so important to ensure that locally you have the patient and family caregiver voice informing the improvement work locally. But just adding on to the advisory councils by creating this larger community and providing more opportunities for people to share their voice and their perspective about improving the way care is delivered in the Department of Health Services. Right now, we are embarking on hosting a bilingual partnership hub. So our plan is to use, like Steven had mentioned, the simultaneous interpretation on Zoom. And so I saw the question in the chat as well about that. And so how that works is when you enter a Zoom meeting, it will ask you to choose a language. And so if I choose Spanish, for example, I will hear everyone speaking in Spanish at 80%. So I'll hear it louder. That will be what I can hear the most. But that still keeps those speaking in other languages like English at 20%. So you can still kind of hear the discussion going on, but you're hearing it interpreted into your language, but it's a lot quieter. So you can really focus on what folks are saying in your language. And there is the translator on there as well, who interprets everything into the preferred language. So that's kind of how that works. And we are going to be hosting our first bilingual meeting in June. So we're really excited about that. But the local advisory councils have been hosting bilingual meetings, and we've learned a lot from how they have been able to do that virtually. They use Microsoft Teams, and I've been able to join a few of those sessions that are hosted bilingual. And it's clunky, but they make it work. And I think that's the biggest takeaway for me here. And I think, we got a few questions about where to start, how to do this effectively. And I think it's just, and like Stephen said too, we're a continuous improvement organization. So as long as we're testing things and seeing what sticks, talking with people who have have experience with this and what we're learning to do, it's just all about starting. So I think that's a little bit. Oh, I also wanted to talk about My Health LA. They are one of the groups who joined us to develop a patient family advisory council. So they were really unique in that first their entire patient population is Spanish speaking. And so they went into the development of their council knowing that this would be a Spanish council. And, they went through some of their community partners, so those community-based organizations within LA County, to open the opportunity to participate on their council. And I think that is huge. And, we always talk about this when we're talking with health systems about really intentionally recruiting for patients and family caregivers that are representative of the communities that you're serving. And that is key, is to get in touch with those community-based organizations. And even if it's not, hey, come join our council, it's going to the community-based organization and sitting down and having a conversation with a patient, just to hear about their experiences and their perspectives. So yeah, I think that's all I had to share there. Mary Lynn, is there any additional cost for translation on Zoom? I believe there is. Yeah, I'll let Stephen.
So you need to have the webinar package. It's only, for whatever reason, that setting is only allowable when you buy the webinar package. So I don't remember the exact cost, but I could get back. I can get back to you on that. It's not the pro level. You need to have the webinar add-on to access the simultaneous translation. Yeah. Yeah. Thank you, Lindsay. So, I mean, we're trying to get into the examples where we've seen people get engaged now, right? So as we're building these pathways for people to get engaged, I think if you really want to embrace the patient family perspectives, you then have those pathways informing one another, right? I think about baking one of these cakes for a research project. I would want to see a research project that maybe leverages social media to understand, like on a grander scale, the preferences, priorities, and goals of people in their target population. Then I would want to see a advisory council level entity. I'd also want to see some of those advisors working on report writing and other operational units in that research, as well as shared leadership roles, co-PI roles and otherwise, and how that information from the social media insights or interviews feeds the advisory council members and drives decisions with co-PIs is a great example of how, like, the Funfetti approach can really center the preferences, priorities, and goals of patients and families in our activity. It helps ground it to what is going to make impactful change for people, and really important. These are how you determine. Yeah. That's a great question, Jerry. I'll get to that. How do you determine if communities feel engaged? You know, this is a funny question. We did a mature story. While I'm trying to get back to that slide. I'm going to say it's another strength of baking patient-family engagement throughout. We had a number of pilot projects we funded in a research effort, and we really wanted to know how did patients and families feel? Did they feel they made an impact? When we asked the researchers in the pilot projects, they said, yeah, they were great, right? They were awesome. They were really insightful. But we've seen before where, you know, our health system partners say that, and patients and families maybe feel they didn't have an impact. And we wanted to go talk to the patients and families. And my ever insightful partner, patient family advisor partner on this said, you know, what's interesting is if we were all sitting around a coffee table, we'd sure hear about it. And it's just an example of how patients and families can support one another in this work and elevate like some of the greatest insights. So I would look at in my research example from just a second ago, like how leveraging some of the PFAC, for example, to have conversations about whether they feel engaged. We first go talk to people, and then we attempt. This is hard and not really done with any level of consistency in the environment I've seen, but tracking where their insights lead to improvements or changes as best we can. We have a success story template. Maybe we could send that out and follow up to the meeting. But great question, Jerry. I think leaning on the patient family advisor leaders to host some of those interviews are a great way to get started with that.
Stephen, can I jump in really quick?
Yeah.
With because I think it's a great question, Jerry, and to what Stephen's alluding to, I was just going to share an example and some work that we're doing with complex care. We were able to create a good-sized community of people representing living with complex care needs, including social needs. And so in thinking about how do we know that they're engaged, I think there's a lot of the conversation that Stephen's referring to, and a lot of the continuous improvement evaluation pieces, and checking in and giving them that feedback as Stephen alluded to as well. That really gets us to hearing from them. I didn't understand that conversation, so I wasn't able to participate. Okay, well then we need to do that differently. And I think one thing I wanted to share that we've learned is it's not always about translating the language into accessible languages. It's sometimes about creating connections between groups of experts. And you guys do that all the time in multidisciplinary teamwork, right? You make the bridges of language and of concepts between specialties. It's kind of the same thing, doing that and making the space for the patient family partners to share their expertise. It may not fit exactly into the conversation, but doing that little bit of bridge building as well. I think what we hear back from patient and family partners is that really helps them to feel that they're having impact in the group. And then I would also say, do you also help others look at equity, disparity, outcomes? Yes, all the time, every day, in every project. Mm-hmm.
And I would add to Libby to not just look at them, but look at them to understand them and engage those who are maybe experiencing inequities or disparities within the health system.
Great addition. Yes, we absolutely encourage that kind of engagement to validate the data and make sure that you understand the story behind the data. Sorry, Stephen.
No, Nadine just popped another good one in there. A tagline or logo for patient family advisory councils. We've absolutely seen that. Yeah, we've absolutely seen that, a label, a stamp, or something, and that really helped gain traction in the organization. They saw, yeah, we don't have that stamp on our sepsis patient education materials. We don't have that on this and others. So yeah, good point. And just to the National Institute of Medicine, I think it did, said one of the most substantial contributors to the sustainment of quality improvement is the engagement of patients and families. If you're trying to reduce sepsis in a hospital, engaging patients and families in identifying sepsis and staying in line with the bundles is one of the most effective ways to sustain that quality improvement effort.
Mhm.
So real cool. I have this slide for you guys too. And after this was question and answer. So I think we got time. And that's my favorite time anyways. But where have we seen people working on QI? And we've seen them, we've started doing, a lot of people wonder, so okay, so what activities should we do? You'll notice we say listening sessions over focus groups, and some of that more inviting language, but interviews, QI coaching, State Hospital Association events, resource development, event planning, presentations. We're trying to bake them throughout our quality improvement initiatives. One of our major projects, working with 300 hospitals across the country. And they've been engaged in all topics of that project, whether it's opioid use disorder, patient family engagement, reducing readmissions. There should be no hospital project on reducing readmissions that doesn't interview patients, engage in improvement activities or teams, and have that patient engagement element to their effort. So yeah, 2 questions. I think one of the biggest ones we get is how do we engage with diverse voices, those who are historically underrepresented or been underserved by our system. And that is really starting small with listening sessions and interviews, I think, going outside of your walls. And that's nothing new, but a transformative day for us at the network was when we moved away from asking people if they want to sign up and get involved with the network, or, hey, do you want to come to this conference with us? Do you want to serve on this action team? Can we nominate you over here? And we are bringing them opportunities to have impact. That's why Libby's been doing this for 30 years. That's why I've been doing it for my professional career. And I think all the advisors in the network share a desire to make things better for the next person, to use their lived experiences, leverage that learning for the system, and give back. I want to give back to the health system that's made me healthy. I can still go surfing and skiing every weekend, and that's a flipping miracle in my book. And I want to make the system better for the next person. I want everybody to experience the person-centered care I had without fighting the way Libby had to. And having those opportunities for impact will bring people to your door. I mean, if you're aligning with change-making levers in your organization and you're using what you learn, I guarantee people are there. Our communities want to see change. We need to address the health challenges of today and the health inequities in our communities. And those solution-focused conversations will come as if we do a good job of deferring that decision-making to communities, helping people elevate their solutions and their challenges, and mobilizing our health system resources and knowledge through communities. I promise if you do that, people will show up, and then compensate. A gift card's great. There are many folks struggling with the benefits cliff to receiving payments. So be mindful of that. But we've seen compensation in a number of ways, including charitable donations. Allow advisors to pick a charity of their choice and have your organization donate. Of course, bring food and coffee. Think of how you can compensate for time. And remember that volunteerism is a privilege. So we'll never reach those voices that we need to hear from most unless we start to compensate that time and effort. What other questions?
Stephen, can I jump in again?
Yeah.
I think the other thing I want to say is that we have to, as leaders of patient-family engagement and really making those connections with our more vulnerable populations, I think we have to become knowledgeable ourselves. We've at PFCC Partners have been on quite a learning journey over the last 2 years, led by, or guided, I should say, by our DEI Leadership Council. So I think we have to acknowledge our privilege and be able to educate ourselves to be trustworthy contacts. And I think that's a really important piece. I think being humble is really important, and definitely keeping that teachable spirit that there's a whole lot we don't know. And I think when you have that openness and you create that trusting environment, people will engage with you, and they're ready to tell you their truth. And the example I just mentioned about our complex care needs group. So we started, okay, we're going to do an advisory board for this project, for this program, and we're going to request or recruit people with lived experience with social and healthcare needs. And I thought, oof, this is going to be hard. We're really going to struggle to get to folks. I was blown away. Typically, when we recruit for a patient family advisory board, we probably get 20, 25 applications. We got 43 applications from the most vulnerable people who were recovering, who were in recovery, who were homeless and had living in unstable housing, and yet they wanted to be heard, and they recognized in the structure of the project that it was an authentic ability to be engaged and to inform what it was like to live with heavy social needs. And so I guess I think a big part of that was really creating a space where I'm not looking to build trust. I'm first just making sure that we are a trustworthy organization. And I think that's a really important first step. So I'm going to add that.
See another good one from Jerry about our health system's focus on social determinants of health, the language and the concept. And I have, this is not based on any, my answer is not based on any conversations I've had with patients and families on the topic. It's my personal thoughts. The ER is not where we want to get treated for all that stuff. And in fact, we're, I think, seeing the failures of our social supports, falling into our medical system. I remember it was Don Berwick, right, at IHI, talking about if an alien came down and looked at our health system, like, why would you wait until then to treat a person with living with diabetes, and instead of going to cooking classes. And I don't think our hospitals are going to become food banks. I think the biggest contribution they have to addressing social determinants of health is mobilizing their knowledge and the resource of our medical system through trusted community entities and spaces. So we can think about taking everything they know about treating diabetes and mobilizing that information and their resource, the tools and the medications, through community-based resource centers, family health libraries, grocery stores, doing cooking classes at grocery stores and otherwise. So that's where I see the vision for our medical system responding to social determinants of health. I don't know how other patients and families feel about it, but that's my answer, Jerry. I don't know. But I invite more questions or insights from the group too.
Lisa, great
Lisa,
question. Oh, go ahead. Let me.
great question about compensation. You know, usually it's a Hoy sandwich. You get Stephen and I talking at the same time, but you know, Lindsay's just been with us so long. Anyway, Lisa, great question. A couple of years, I think it's been 2 years now, Lindsay led a work group within the PFA network that produced a compensation guideline book. So we'd be happy to share that with you. It came from the patient family advisors based on what their experiences are with compensation.
Yeah, I'll find that and share it. Thank you, Lisa. I also wanted to mention, so I mentioned the equity, diversity, inclusion, and anti-racism listening sessions, EDIA for short, in LA County for the Department of Health Services. So they hosted a variety of listening sessions with different groups of people. So patients, community members, healthcare professionals, administrators, et cetera. And they knew that they wanted to compensate the patients and community members for their time being on the listening session. And I actually got to talk to them a little bit more about how they kind of figured out that compensation process and what they actually did, because as Stephen mentioned, there is a benefits cliff where you receive compensation that is over the line that impacts the other benefits that you're already getting. And what they did was they connected with an attorney and allowed patients and community members to speak with an attorney to learn how any extra compensation would impact their benefits. So I thought that was kind of a progressive way to help the patients, but you know, it is a lot larger of a conversation that we're having with the PFA network as well, as to, you know, how can we really compensate people for their time without having that impact on benefits. But I thought that was one way to kind of support patients with a solution. And I will find the compensation guidelines that we have and put those in the chat.
Yeah, it's still evolving. You know, 5 years ago, we've been getting asked a similar question: how do we engage more diverse voices in our activities for years? And we used to joke 5 years ago, well, give us a little budget, we'll fill the room, right? And now I think we can make that argument a little easier now with our health system and having a little more commitment and resource toward engagement. We do, you know, we look at something like a focus group or interview for an hour, around $75. You know, shared leadership roles up pushing 100, 150 is something I've seen in our work proposals more often now, being accepted by funders. And when we go to disseminate those, we try as best we can to leave it open to their preference, whether that's a charitable donation. Some people turn it down and say, you know, I don't need it, send it to somebody else. But leave that option open. We've sent Venmos, Amazon gift cards, checks in the mail. You know, we just try, we try as best we can to offer as many options as possible for them to receive that. And if they need, and as Lindsay said, you can go a step beyond and offer support and understanding how that compensation may impact other social benefits that they're leveraging. Gasoline cards, that's brilliant. Liquid gold, liquid gold. That's brilliant. I had not thought of that. Jeez. experience.
Thank you for that resource, Lisa.
Yes,
Oh,
thank
and Metro cards too. Great, Adeline.
Well, Stephen, we're right at the top of the hour. Any final insights?
Reach out if you want to build a patient-family engagement strategy that'll meet your organization's strategic goals and priorities. We're here to help in any capacity. We've done it a few times. We've learned plenty of things along the way, some of those common pitfalls, and your PFCC Partners team is here to help.
Awesome. Absolutely. Well, thank you so much, Stephen, for this presentation today. And thank you to all of our participants. Great questions, great conversation in the chat. Really appreciate you again joining us on your Friday afternoon. And we hope that you join us next month, same time, same place, and be safe. Have a very safe and happy Memorial Day weekend. Thank you.
Yes, hope it's kind and restful to you all.
Thank you. This was wonderful.
Nadine. Bye, everybody.